Hi everyone. Thanks for joining us tonight. I'll just start off by telling you a little bit about myself. So my name is Dr. Melanie Altas. I'm a gynecologist. Currently now I work at in Vancouver Coastal Health at PGH, and my practice right now is completely dedicated to chronic vulvovaginal conditions, sexual medicine, and menopause. And I started doing this about five years ago. And prior to that, I was a community gynecologist in New Westminster. And over my 13 years in community practice, I developed a niche interest in this area because I very quickly realized that this is an underserviced area where a lot of women are suffering with debilitating conditions and not receiving what I would say is timely or appropriate diagnoses and treatment. So this became a passion of mine, and so I'm really excited for us to be here. Tonight to present on this. I'm going to start off by talking about more medical aspects of vulvar and or sexual pain. I'm going to speak for about 25-30 minutes, and then we'll have some time for questions. And then Dr. Lori Brotto is going to do the second half on the psychological aspects of sexual health. And Kaku, can you just go ahead with the slide? So these are my formal objectives, but basically what I would really like to do by the end of my presentation is to give you confidence in recognizing vulvodynia, or recognizing when someone is presenting with sexual pain. I want to give you confidence in making a diagnosis, and not only that, but responding to people who are experiencing sexual pain. Kaku, can you go to the next slide? So just to start off, so we're all on the right page. I'll start off with the official definition of vulvodynia. So vulvodynia is a vulvar pain of at least 3 months duration, and this is what makes it chronic without a clear identifiable cause. And I'm going to go into what that means a little bit later, but with potential associated factors. So in brief, vulvodynia is a diagnosis of exclusion. Now, that does sound kind of really, really vague. It's not really a clear-cut diagnosis. And I'm hopefully over the next 20-25 minutes going to make this a bit more clear for you. So when, Kaku, can you go to the next one? So when should you think about vulvodynia? So this would be if you are talking to someone who experiences pain with a pelvic examination. So this may be with a Pap test. You may see this person coming in for routine pelvic examination. Someone who reports that they experience pain with tampon insertion, are not able to insert it. Someone who experiences pain with sexual insertion, either partnered or self. Someone who experiences pain with tight clothing, particularly thongs, tight exercise leggings, or the ribbing from jeans, or someone who experiences pain with exercise, such as bike riding. Next slide. So what do we hear people say particularly? So a common presentation that I'll hear in my office is someone saying, whenever the opening to my vagina is touched, it feels like it's on fire, or it feels like it's like acid is being poured on it. And this is a really common presentation. And this is a presentation that we call localized. So it's localized to the opening of the vagina, and it's provoked, which means that the pain is there with any type of touch, and then it resolves. You can, next slide. So I've used the words, feels like it's on fire, burning, acid-like, but a lot of people will use different words to explain the pain associated with vulvodynia. We'll sometimes hear stinging, raw, swollen, throbbing, even just a pressure sensation. So any of these words come under the umbrella of vulvodynia. Next slide. So I've already mentioned to you one of the subtypes of vulvodynia, which is localized provoked vulvodynia. And that's by far the most common type of vulvodynia that we see. But there are a lot of different subtypes. So some people will talk about experiencing generalized vulvodynia, and that may be where they experience pain everywhere on the vulva. We'll have some people where it may be localized to the opening of the vagina, which is called the vestibule, or maybe the clitoris. The second subtype is it provoked or not? So like our patient that I mentioned, it's there with touch and then it goes away. Or there are people who experience vulvar pain where it's just spontaneous. So maybe someone, the question I usually ask is, when you wake up in the morning, do you experience the pain? The onset, is it immediate? So the pain, the trigger is the touch and they experience the pain right away? Or do they maybe experience pain after intercourse that lasts for a while? And timing, this means primary vulvodynia, which is pain that is there right from the very beginning. So from the time that they tried to put in a tampon, maybe they'll remember feeling pain when they were bike riding as a child. Or secondary vulvodynia, so where the pain was develops after a period of pain-free intercourse or pain-free touch. On to the next slide. Now, if you remember, I had mentioned in the definition these potential associated factors. And this was a really important part of that definition. And that line of the definition was added in 2015. And this is what individualizes the approach to vulvodynia. So when we're assessing someone who's experiencing vulvar sexual pain, we want to look at all of these things. Comorbid pain conditions, do they have endometriosis, do they have painful bladder, any genetic component, are there any hormonal factors such as menopause, are they on the birth control pill, are they postpartum, history of inflammation like yeast, bladder infections, is there a contribution of the pelvic floor? Or is there nerve sensitization? And this may be the nerves that are just underneath the skin, which is peripheral sensitization, or central sensitization where the brain and the spinal cord are upregulated or sensitized. And then we also have psychosocial factors. So these may be relationship factors, anxiety, depression, trauma, history, OCD, ADHD, all of these things come under this heading. So what is our approach to someone who's presenting or reporting vulvar and sexual pain? Well, when we're making a diagnosis, if you want to go into the next slide, I think before we jump into the details, I think it's important to touch on why is it important to make the diagnosis of vulvodynia, and also why is it so hard to make the diagnosis? So making the diagnosis is really important. Do you want to do the next slide? Because it's common. So conservatively, it's estimated that 8% of people with vulvas have vulvodynia at some point during their lifetime. But there are some population-based studies that suggest this is likely up to 16% of people. We know it's underdiagnosed. So 60%, so almost 2/3 of people with vulvodynia will see 3 or more doctors before getting a diagnosis. And I've seen many people who have suffered for 10, 15, 20 years without getting a diagnosis. And we also know that the symptoms of vulvodynia have a debilitating impact on quality of life and cause significant psychological, relationship, and sexual suffering. So, next slide. So I find sometimes when I give people these statistics, sometimes these statistics can have an impact. But what I've found in my practice is that hearing the stories and hearing someone's narrative can actually be much more impactful. So I'd like to take a minute just to give you a story of one of our patients. So she said, I had trusted these experts who said it was all in my head, and I believed that if my pain experience wasn't real, then something must be really wrong with me, mentally and emotionally. I was isolating myself because of this shameful secret of PVD, of provoked vulvodynia. I felt completely alone in this pain and couldn't talk to anyone about it. There was cultural shame and wondering if the pain was a punishment for having sex before I was married, and personal shame from this idea that sex was supposed to come as naturally as breathing, sleeping, or eating, but I kept failing at it. I know you can't change the past, but sometimes I wonder what would be different if I'd been diagnosed properly earlier when I was in my early 20s. So I've heard this story many times, over and over and over again. And one of my professional missions is to try to change stories like this. We'll go on to the next slide. So if it is so common, so it's up to 16% of people with vulvas, then why don't we hear about it? Well, there are a lot of barriers. Next slide. There are a lot of barriers, and I would divide these into patient barriers. So things such as shame, confusion about the pain, people thinking it's yeast infections, a lot of people thinking it's hygiene related, which it never is. A lot of search for causes and useless treatments. So using a lot of over-the-counter products. And I think I've already made the case for the condition itself can make it difficult to diagnose. So there are a lot of different presentations and a lot of different subtypes. But then there's also a lot on the physician or the provider side. So in medical school, in residency, I know in nursing school, midwifery school, there's a significant lack of education and teaching to healthcare providers about women's sexual health. I know when I went through medical school a long time ago, I didn't hear the word vulvodynia, sexual desire in the context of women at all in my entire 4 years. So if you want to go on to the next slide. So we did a survey just to emphasize this at one of our women's health conferences a few years ago. We did a survey looking at how comfortable were healthcare providers at diagnosing and treating vulvodynia. So in this sample, we had 120 people respond, and there's a lot of bias because these are people who are already interested in women's health. So the true numbers are much less. And basically we found that 25% of family doctors and gynecologists were uncomfortable diagnosing vulvodynia, and almost 70% were uncomfortable treating vulvodynia. So those are big numbers. So next slide. So we wanted to explore what are the barriers and how can we remove these for patients and community physicians. Next slide. So we got a grant through something called Shared Care, which is a sort of an initiative with Doctors of BC and the Ministry of Health to develop an online toolkit to provide to support family doctors in the community in helping their own patients. On the next slide, I'll give you the link. So we call this the Vulvodynia Primary Care Toolkit. And I'd like you to explore this because it goes into detail for primary care providers, so frontline people who are talking to and diagnosing people with vulvodynia. And I'm going to pull out a couple of the resources I think would be helpful. On to the next slide. So details around the diagnosis. So we're going to touch on some tips with history and physical exam. Next slide. So if you go into the primary care toolkit, under the screening and history, we have a list of questions that should be asked of people who present and talk about sexual pain or insertional pain. Next slide. However, what we tell our residents and our medical students is that overall the vulva is not a good historian, and it's really important to do a physical examination. Next slide. So what we really want to rule out are all of the things that you can see on the skin. So things like skin conditions like eczema, psoriasis, something called lichen sclerosis, Infections like yeast, herpes, HPV, UTIs, bladder infections. You want to look at for the hormonal status, menopause, postpartum. We also know that the birth control pill can decrease the hormones in the vulvar and vaginal skin. Are there any pre-malignant or malignant conditions? Or are there any of the major nerve conditions? So things like pudendal neuralgia, or does someone have nerve pain after herpes infection? So those are all of those things that we want to rule out. And that's what makes vulvodynia a diagnosis of exclusion. Next slide. So I think one of the questions that that someone gave to us ahead of time was they wanted to know what to tell someone when they're going for an exam or seeing a doctor. And I think these are really valuable points that you can give to a patient in helping them have a physical examination, and things that a patient can advocate for during their exam with their primary care provider. So they should know the purpose of the exam. Why are they having the exam? So it's to rule out all of those other conditions. The patient can ask to have a description of what will be done during the examination. They should also know that they're in control and that they can ask the exam to be stopped at any time. And it's surprising to me how many people tell me that they didn't know they could ask a doctor to stop. If they know some things that would help, they should mention this. They can ask that the exam go slowly. They can also ask to have what I call an educational exam. So using a mirror to see what the physician is doing and what they're examining. Next slide. I have in my office these models of the vulva. They're from a store in Montreal called Granville Biomedical, and I use this to explain the exam to the patient ahead of time. Next slide. But basically, during the clinical assessment, we're going to touch on what I've already mentioned. So the visual examination of the vulva to rule out all of those conditions. We're going to do something called a Q-tip test or cotton swab exam, which I'm going to show you on the next slide. And we're also going to do an assessment of the pelvic floor muscles. And this you don't need to have a speculum inserted or have the physician's hand inserted fully into the vagina. Many times, if I'm examining someone externally and I see them pull away or I can see an involuntary contraction, that to me gives me all the information that I need to know about the pelvic floor muscles. It's tight, and I can tell that without putting a speculum in or doing a full exam. So on the left is a picture of the vulva, and what I've outlined there is the vulvar vestibule. So this is the most common place for the localized provoked vulvodynia. So I've drawn, you can kind of see the outer lines, the more lateral, are at a place on the vulva or the inner lips called Hart's line. And this is where the vestibule starts. And you can kind of see there's a difference between the two types of skin. And then the hymen, which I've circled on the inside, the hymenal tags, that's where the vagina begins. So this is still a part of the vulva. And this could be a really important part of the educational exam when you're examining a patient. If you have a mirror, you can show them all of these parts, where their clitoris is, which is up here, where the urethra is, the bladder opening. But what we want to do is this Q-tip test. So provoked localized vulvodynia is diagnosed when there is sensitivity to light touch. So when I touch in those 4 areas, so 11 o'clock, 1 o'clock, 5 o'clock, and 7 o'clock, and I ask the patient to rate this on a scale of 0 to 10. And technically more than 3 or more is consistent with the diagnosis of vulvodynia. So that's how we try to quantify it. We'll go on to the next slide. So let's say that you've made the diagnosis of provoked vulvodynia. Where do you go from here? So this is where a lot of providers kind of get caught up and get blocked. So what you want to do, and we have a lot of resources on that toolkit, you want to tell them the symptoms are real and they're common. You've heard about this before, and actually up to 16% of people will have this at some point. Explain the diagnosis in basic terms, which I'm going to give you some advice on the next page. Provide reliable online resources. Remove what hurts. So have an agreement with their partner to focus on non-insertional intimacy. And we have some handouts on the toolkit on what non-insertional intimacy can look like and some ideas. Also invite the partner for follow-ups. But basically what you want to do initially is instill hope. If we go on to the next slide, the next slide was a study done in Newfoundland, a qualitative study, and I love qualitative studies, the storytelling and the narrative. But you can see this was the question that was asked: did getting a diagnosis of something change your outlook about how you experience the condition? And you can see the highlighted words: the hope, relief, taking me seriously, felt validated. So those are powerful words, and they can really change the trajectory of a patient's experience of their medical condition. And so that's why I think that providing that clear diagnosis is really, really important. So let me give you some tips on what not to do on the next slide. So don't invalidate the pain, which and by that I mean saying things like, which we still hear, it's all in your head, just relax, have a glass of wine. Saying things like you know what it is, you've heard this before, that it's common. Those are ways to validate the pain. We recommend not using lidocaine or a numbing gel for insertional intercourse. One, it doesn't address the root of the problem. It doesn't allow the person to experience oral sex, which for many of patients with vulvodynia, this is their only source of pleasure. But also it's a bit of a patriarchal, heteronormative approach to sex, where the goal is just to insert a penis into the vagina, and that's not really what we want to aim for. We also see a lot of people who will prescribe vaginal dilators to patients at the first visit, and we consider this an advanced physical therapy technique, and I wouldn't give this to someone at the first visit. It scares a lot of people. And they don't know what to do with it, and we just find it doesn't work, and it can kind of lead to more frustration. So next slide. So what works for vulvodynia? So we know that education is very powerful. Psychological skills, specifically cognitive behavioral therapy and mindfulness. Pelvic floor physiotherapy is very important. In some instances, surgery, removing the painful tissue, and Botox can be helpful in some situations where someone has really tight muscles that don't respond to physiotherapy. So on the next slide, I've written down our website. So it's bcvulvarhealth.ca. And on the, there's an animation there, Kaku, if you hit the next one, next button. So under community resources and alternative health providers, we have a list of vulvodynia aware physiotherapists and psychologists and counselors. So you can give those as resources to patients. And those are for people throughout British Columbia. Next slide. But we know that patients experience a big gap in care once the diagnosis is made. And I think this is where we can very easily fill this gap. And why do I know this? Well, if you look on the next slide, this is our intake questionnaire. So this is a referral that we got, and the doctor wrote on it for vulvodynia. They saw, the patient checked off, they saw a family doctor, they saw a gynecologist, but when you look down, it says no, they did not get a diagnosis. And this is very different from the physician notes that we received. Next slide. So if you go to the toolkit, we have a whiteboard animation that is about 5 or 6 minutes going through what is vulvodynia. So what's actually going on in the body? Because this, even though I explain this to people, so I see about 10 people per week with vulvodynia, I know in practice, most people don't see that many people. So you're not going to get into the habit of explaining it yourself. So this is on YouTube. You can email it to a patient, or if you're doing virtual health, they can use this QR code. But basically on the next slide, we go through 3 different components. One is peripheral sensitization. So this is where underneath the skin, the superficial nerves going to the surface are sensitized. They're upregulated. When they're touched, they're going to cause burning pain. And I find it really helpful to tell people that, yes, your skin looks normal because what's going on is underneath the skin. And that's why sometimes the skin may feel swollen or look red, because these nerves are really active. And then when those nerves are active, you're going to get an increase in pelvic floor tone, we call pelvic floor dysfunction. And then you're going to get something called central sensitization, where the nervous system is upregulated. And this can change the way that someone experiences pain. And if I would invite you to take a look at the whiteboard animation because it goes through things in detail. Another resource I love on the next slide is another whiteboard animation on how sexual vulvar pain can impact the sexual response cycle. And that's also very validating for patients to understand how this relates to desire. Next slide. So it's common for people to feel a lot of grief and anger, a sense of failure, but also loneliness and isolation. I see almost everyone I see will have this experience of being the only person in the world who has vulvodynia. If you go on to the next slide. So to address this, in our clinic, we have a lot of groups, and that helps to address this sense of loneliness. But in rural settings or where there's geographic or professional or personal barriers to accessing our clinic, we have 2 patient stories that we've recorded. On the next slide, the National Vulvodynia Association has a lot of patient stories, and they have one video. This is a really great video. And all these videos are really optimistic and hopeful. On the next slide, this is an amazing organization that I direct patients to. It's called Tight Lipped. It's a patient-led grassroots organization that provides a lot of peer support for around vulvodynia, and they are also huge advocates for increasing education in residencies and medical school. So just to end on the last couple of slides, I want to come back to these potential associated factors because you may be asking me, well, yes, education is great, but where do we go to next? And this is where the individualization and patient-directed approach comes into play. So I have a huge, like 2 to 3 hour long talk where I go into this, and we don't have time to do this today. But I really invite you to tie in your history, your physical examination, your education, all to these potential associated factors. And if you go on to the next slide. And to combine this with the patient goals. So what does the patient want? Do they just want a diagnosis? Do they want to maybe get pregnant? I have some people who just want to be able to insert a tampon to go swimming. We assume that sexual activity is the goal for everyone, but it's not. So using the patient goals, coming back to those potential associated factors, the contributing factors of your patient, it then helps to guide you in determining the direction of treatment. So on my last slide, I just want to come back to really emphasize that vulvodynia is a devastating condition, and unfortunately, it's only exacerbated by patients' experiences within the healthcare system. And this is why I feel it's really important that the point of entry into the healthcare system, so that first phone call, that first virtual visit, that first in-person appointment, is positive and hopeful. And I also really want to emphasize what seems simple can actually have a huge, huge impact. So I'm going to end there and see where we are for
Oh my gosh, you're so good on time. Thank you, Melanie. That was fantastic. Yeah, I think we could just open it up. If anyone has questions, I can monitor the chat, or if you feel ambitious and you want to come off in the evening and just ask your question, take your mute off and join us. And if you're shy and you don't feel like it, you can always send questions after and we can share them with the team as well. Kaku's nodding.
And
I
I
think
think we'll also have time for questions at the end
yeah.
too.
I mean,
So
I think it's
out
really
there.
important because a lot of our staff and a lot of our nurses are doing pelvic exams on the regular, more from like a very disease perspective. And often you encounter patients who may, have underlying or unprovoked vulvodynia, and you're trying to push through around like the disease cycle and ensuring that people get their exams. But it's something to just like slow down. And I really liked how you talked about instilling hope and having that positive experience. I think that's a really great place to start. So yeah, I definitely will take that away. Okay, Anita has a question here. Can you see those questions, Melanie? Do you want me to read it out?
Yeah, maybe
Oh,
read it
yeah.
out. I can see the
Yeah,
chat.
so she just said great presentation and timely as they've had quite a few clients come into their clinic. I think the resources will provide a really great option. So I will pull those, Anita, and put them along with the presentation.
I'm not going to show my face because I've been marking papers all day. I look like shy. There's the Irish coming out. But yes, Melanie, thank you. We've had a few come into the clinic in Nanaimo with this and talking about it. And you're bang on about how they're feeling and how they are knocking themselves down and about that. So I think, as all practitioners, it's our duty to make sure that they walk away feeling a little bit more at peace and that there's not something wrong with them, air quotes here, that how we walk them through it. So thank you for this.
You're welcome.
Yeah, I found it interesting with that chart you shared with us is like the physician obviously had an idea that this is likely what it was, but didn't share that with the patient and then referred them on. And unfortunately, had that been backtracked or been explained a little bit prior to that patient referral, they could have been empowered to seek out some of the knowledge that they needed through these awesome resources you're sharing. So yeah, I think it's trying to get away from that mentality. I think that we learn in medical school or nursing school or whatever around gatekeeping, and really empowering the patient to be able to be the keepers of their knowledge is very valuable. Okay, great. I don't see any more questions coming through. And like we said, we'll have some more time for questions. It's 7:17, so I think we should push through and welcome Dr. Lori Brotto for the next part of this presentation. Great. And Lori, you're all set up there, so you can come off mute. Oh, I saw you and then you left. I saw your presentation and then it left.
Oh, let's see. How
There you
about
go.
now? Is
Yeah,
it there?
got ya.
And you can hear me?
Yes. Good
Okay.
sound check, and I can see your presentation.
And I'm not supposed to see anyone. I don't see anyone on my Teams. Is that right?
You can set your view, but
Okay, I'm just gonna leave it.
Leave it, and if something comes up, I will jump in. If a question comes
Okay.
up during your presentation, I'll just bring it if it's
Sounds
timely, or we'll
good.
just save it to the end.
Yeah.
Okay.
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 I managed to avoid Teams for most of my life. So I appreciate your help and your hand holding, Nicole.
Okay,
Thank you so much. And Dr. Altas, that was a fantastic presentation. And thank you for setting up the conversation so well tonight. And what I'm going to be focusing on during my portion of the talk is really, as a registered psychologist in BC, is much more the kind of psychosocial interpersonal aspects, and also a focus much more on sexual desire, arousal, and orgasm difficulties. I'll say at the outset that you'll hear me refer to women often in this presentation, and where possible, I will be accurate and say women and gender diverse persons. The reality is there is a dearth of research information that has been completed on this topic of sexual dysfunction in birth-assigned females who don't identify as women. There's a little bit of data. There's a huge need for much more information on that topic. So I'm going to try and be precise in my language throughout in referring to the individuals who participated in the research studies. So what I hope to focus on for my brief time is to really empower the folks who are tuning in to think about, how do you know when the person who's calling in on the sex sense line or who is seeing you in one of the options for sexual health clinics, whether this is a kind of understandable and adaptable sexual difficulty versus a sexual dysfunction. I'm going to spend just a few moments talking about asexuality, because it's really important to distinguish asexuality from low desire, so as not to diagnose folks who identify as ace. And then we'll talk about the major evidence-based treatments, again, with a focus on the more psychological perspectives. I'll give a nod to some of the Health Canada approved medications also for low desire. And so some of this was inspired by a collaboration that Nicole and I had 5 years ago in 2019. We took a look at, among the callers of the sex sense line, what were the kinds of calls that they were asking about. And this is a table taken right from the publication, and GSH, general sexual health, we included a definition that included really questions about sexual function, sexual dysfunction, genital pain. You can see that 18% of the callers in the last year of the data collection were about that topic. So quite a sizable number of the calls were about that. In fact, you could say that was the second most popular topic after, of course, contraception, and tied with STIs. So really glad that Dr. Altas and I have some space to talk about these issues in a bit more depth. And of course, you may have picked up already that we're talking about largely assigned female at birth specific diagnoses tonight, and maybe a future talk will be specific to the assigned male at birth population later on, although we may need to get a different speaker for that. So let's start with, how do you know when the person in your office, whether this might be in the domain of being a sexual dysfunction versus what is normal? And, unlike many other areas of health, of medicine, where we have objective criteria to define what is a disease, what is a dysfunction, when it comes to the very common sexual dysfunctions, desire, arousal, and orgasm, we simply don't have those objective markers. So we're really basing the diagnosis on the person's level of self-reported distress. And so, we can think about, what is a sexual concern? Maybe this is the person who calls in the sex sense line and says, I think I'm concerned because I just don't have the same amount of interest in sex as I used to have 5 years ago. We would say that that's a concern. The person who says, I don't have the same level of interest and it worries me. I talk to my friends, they seem to have higher desire, they tend to masturbate once a week, what have you. Am I normal? And then this third level where we would diagnose a sexual dysfunction is if the difficulty is persisting, and the DSM-5, which is not the only classification system, but it is certainly something that mental health practitioners use, says the difficulty has to persist for at least 6 months, and there needs to be clinically significant distress. And the distress has to be by the individual. It has to be the person themselves saying, this bothers me, this interferes in my life and my well-being. Distress by a partner is not sufficient for the diagnosis. And this is really important because it's very often, again, as a clinician, I'll have couples come up into my clinical practice and one partner will say, I've lost my desire. And the other partner will say, and it really bothers me and it bothers our relationship. And yet the main person will say, and if I never had sex again, I would be fine with it. So that questioning about distress, that it needs to be personal, that it needs to be clinically significant and bothersome is really, really important. I mentioned the DSM. Again, it's not the only system of classification. Physicians and our European colleagues are more likely to use the ICD-11, where there are some differences in the specific criteria for the sexual dysfunction. I was actually on the DSM-5 committee 2009-2013 that led to the diagnoses of the sexual dysfunction. So I know a lot about the individual criteria. I'm only going to spend a few brief moments describing these to you. Again, more so, not so much that you're going to be diagnosing these issues, but rather that you have a sense of, what might be something that's really clinically meaningful and important versus what might be something that I want to provide some reassurance to the person that, well, it makes sense that you've lost your desire, you've just had a surgery, or you've just gone through a very stressful period. How can we support you emotionally and kind of trust the process that your desire may surface after? So that's really the purpose in me talking about some of the DSM conditions. You'll see that they're separated by sex. So there's the female specific ones, the male specific ones. And I'm just going to focus on a few of these. The first one, sexual interest arousal disorder. This is the person who says, I have no desire. I've lost my desire. For those of you who are interested more specifically, we do ask about these different domains of low desire. And so the diagnosis itself, which again, you may or may not be doing in your own clinical practices within Options for Sexual Health. But again, just to give you a sense of what these patients might say, they might say, I've reduced interest in sex. I no longer initiate. I don't respond to a partner's advances. My overall pleasure is down. I never really fantasize. I don't have spontaneous thoughts about sex. My overall kind of arousability in my body has been diminished. And I don't respond to the typical cues or triggers like I used to. So maybe this is a person who used to respond with a lot of desire when they read or watched erotica, and now they're saying, meh, it doesn't do it for me anymore. And again, the symptoms need to persist for at least 6 months. Female orgasmic disorder. So importantly, not reaching orgasm through vaginal insertion activities, whether the insertion is with a penis, a dildo, a strap-on, a finger, what have you. The data tell us that about 80% of people with vaginas do not experience orgasm through strictly vaginal insertion. And so we need to be really careful when people are presenting with difficulties with orgasm, that we're asking a lot of questions about, tell me about the kinds of stimulation that you're doing, where are you stimulating? I often even ask people to kind of walk me through a recent sexual encounter or a recent masturbation experience. So this would be the person that would have either a reduced intensity or a significant delay in experiencing orgasm, or absent orgasm altogether, and that the difficulties are persistent. And Dr. Altas, who focused on provoked vestibulodynia and vulvodynia, the DSM-5 would categorize that within this bucket called genital-pelvic pain penetration disorder. And so I'm not going to discuss that. One of the things that the DSM-5 does really well, and if you have a copy of it, there's a section that kind of describes all the associated factors, and it really guides the clinician to pay attention to what might be some of those other contextual parts of the person's life that can directly be contributing to the sexual difficulty. And so some of the questions that we ask about are, has this always been the case, or is this something that's more recent? So for example, the 24-year-old female who's never been able to experience orgasm in any sexual encounter, we would say that's lifelong or primary. And then we also ask questions about, is it partner specific? Is it only with your long-term partner, but maybe with a lover, the difficulty isn't there? Or is it in all encounters with all partners? So the 58-year-old who has a new pain with intercourse only, but no pain with masturbation. So that would be generalized. So sometimes asking those questions about how long it's persisted and its contextual nature can also guide you in thinking about your treatments. So these are some of the domains that the DSM-5 encourages us to think about. How is a partner contributing to this? And it may be that one individual who is showing up in your clinic or is calling the sex sense line, but asking some questions. Who is your sexual partner? Do they have their own sexual difficulties? What sort of role are they playing in this? So as a concrete example, the person with very, very low desire who says, I have a partner who doesn't want to engage in any kind of arousal activities. We only have spontaneous, unplanned intercourse. There's no sort of buildup. There's no arousal, and it hurts. So having that context, is really, really important. You wouldn't prescribe a medication for that person, not that you would anyways, for this case, but really having a conversation about the importance of arousal and lubrication would be really important. We do also ask about relationship factors. And, as a telling example of this, very often females will say that they can experience orgasm on their own during masturbation, and that's much more challenging with a partner. So are there kind of partner pressure related factors? Is there a performance demand where there's a kind of expectation about reaching orgasm? Are there references or statements made to past partners who were easily orgasmic? Sounds pretty cruel, doesn't it? But unfortunately, it does often come up. So those would be some of the factors that we want to keep in mind. Certainly cultural and religious factors is something that's really, really important for us to keep in mind, while not making any effort whatsoever to challenge or change a person's cultural upbringing related beliefs or religious factors, but understanding them and maybe posing some questions in a bit of a Socratic way. Help me understand the impact of believing in the importance of preserving sexuality for marriage on your current challenges with orgasm. And that's just good, culturally safe and sensitive care and practice that we all bring. We do want to know about concurrent medical factors that's relevant. So I do a lot of my work and my research in the space of cancer survivorship, where there are both medical factors such as chemotherapy, radiation, surgery, changes in sensation that can directly contribute to sexual problems, but there's also psychological factors, changes in body image, having a brush with death, having changes in your relationship such that maybe your partner is no longer a lover, but is seen more as a caretaker. And so understanding that those contextual bits is also really, really important. And then finally, the individual vulnerability factors. So these would be things like, history of depression, anxiety, both of which we know are often concurrent with low desire and other sexual problems in females and in males, in fact, in all people. And understanding particular beliefs and expectations as well. So is this a person who kind of enters into a sexual encounter with a hyper focus on the outcome? Am I there yet? Is that the start of orgasm, et cetera? And being very concerned about impact on the partner if they're not. So these are kind of some of the really important contextual factors to keep in mind. Just how common are these difficulties? This is a study we often cite because it was among the more methodologically rigorous studies. It's a bit outdated now. NatCell4 data have been collected already. They just haven't been released yet. And I'm happy to know that in NatCell4 they were very intentional about recruiting gender diverse persons to attempt to get some prevalence data among those folks. But in NatCell3, you can see the prevalence here. So low desire, which is mostly what I'm talking about today, is not only the most prevalent of the sexual difficulties, but it's also in the men who were recruited. It was also the most common of the sexual difficulties. Now, one of the things I really love about Sex Sense, among other things, is its anonymity and its confidentiality. And this is so important because in the domain of sexual dysfunction, the vast majority of people actually never seek help. They never talk to a family doctor. They never reach out to a sex therapist. You can see this was a study published a few years ago that a tiny fraction of the women and men actually sought treatment. And there are both patient barriers related to embarrassment, but also healthcare provider and physician barriers. And again, this is why anonymous opportunities to seek help like Sex Sense are so important. So I'm going to say a word about asexuality because unfortunately there continues to be a misunderstanding and a myth that asexuality is a sexual dysfunction. And I certainly, when I began doing research, trying to understand asexuality back in 2006, it was because a psychiatrist that I worked with said, well, aren't those folks just the extreme low end of the low desire continuum? And maybe they've had some trauma. And so they've kind of incorporated this identity as an asexual person. And nothing could be farther from the truth. What we do know is that ace people represent up to 3% of folks in nationally representative surveys. By the way, what is asexuality? This is the person who says, I'm not sexually attracted. Sometimes they'll say I'm not sexually attracted to anyone of any gender in any circumstance. And sometimes they'll say, there are very select situations in which I experience a little bit of attraction, but for the most part, I do not. and David J., who founded the largest online community of asexuals, which is www.asexuality.org on the screen. Keep that URL handy. It's an incredible resource for people, even who might be questioning their ace identity. And there's a whole kind of subsection within AVEN that helps people kind of think through some questions to help them sift through whether they might be ace or not. Within the ACE community, you can have folks that also identify as aromantic. So in addition to lacking sexual attraction, they similarly lack any interest for the non-sexual, more romantic parts of a relationship, versus the folks who do have romantic attraction. So you can have an ace, an aromantic asexual, or you can have a romantic ace, someone who lacks sexual attraction but really continues to desire the more emotional, non-sexual parts of a relationship. And you can see the breakdown there. In terms of gender identity, you can see it's a beautiful, rich rainbow of different identities for folks in the ACE spectrum. So that's all I'm going to say about asexual. Oh, no, I'm not. I'm going to say one more thing. And that is, if anyone is interested in hearing a bit more about the research that we and others have done, we've looked into, is this a psychopathology? Is this kind of a manifestation of trauma or an interpersonal difficulty? And the answer to that is no. Is a paraphilia maybe, where the kind of the target interest is misplaced? And the answer to that is no. Is this just an extreme low desire? Variety of studies that have tried to unpack that, and the answer is pretty clearly no. And most of the data and most of the experts in the field would concur that this is a unique sexual orientation. I was part of a great CBC series called The Big Sex Talk, and episode 2 is all about asexuality, and it's mostly focused on folks who live as ace, and then I and I think one other person kind of fold in some of the science. So that's a great free resource that you can also share with people who might be exploring their ace identity. Okay, so I'm going to spend the rest of my time now really focused on what you can do as an options for sexual health staff, presuming that you're not a sexual dysfunction expert per se. I know that you're all STI experts and sex education, et cetera, experts, but maybe you wouldn't identify as being kind of a sex therapist or a sexual dysfunction expert. So what can you do? Do I have that right, Nicole? Yeah, okay, good. I don't want to misclassify anyone and then all the sex therapists.
No, I think we would all say we need support in this. Yes.
Okay. I don't want all the sex therapists to get on and throw tomatoes at me through the screen. So this is probably the most helpful model that exists. It's an old model, but it persists because it is so helpful. And it's a great acronym to remember for yourself. And the acronym is PLICIT. So I'm going to walk through each of these because it'll help you decide what is within my wheelhouse and my comfort zone that I can do given the training that I have, and what really falls outside of my expertise where I really need to refer someone on. So starting with the P is about permission giving, and there's a variety of ways that you can do that. One of the things we know, and this is based on a lot of research that has looked at people who have seen a sex therapist and what are the most important characteristics that that patient has said about their therapist. And it's not how excellent they are at delivering CBT. It's the top one was empathy and warmth. And these are all skills and characteristics that I know you all have. You can be interested, you can be warm, you cannot be phased when they're describing how they masturbate and how they try and reach orgasm. You can have some training in the field. If they perceive you as trustworthy, and there's ways that you can do that, you can have some facts and figures at your fingertips. You could look them in the eyes if that feels comfortable for them. Other people do not want to look at you in the eyes. If you can practice to not be embarrassed. And this comes about with exposure. So the more that you can talk about these topics, the more comfortable you will feel. If you have any degree of familiarity, so maybe they saw you in the past for their UTI, their Mirena insertion, and now they're coming back to you and talking to you about sexual health, that familiarity can help. Humor, believe it or not, goes a long way. And it's hard not to crack a joke about sexual health when you work in this space. There's so many puns and things that come up that you can fold in, et cetera. So these, in the way of permission, can convey to the person that you can be trusted, that this is a safe person to talk to about my concerns. You can also have books on your shelf or have a list of books handy. This summer, the New York Times published their top 8 favorite recommended sex books. A bunch of them are on the screen right here. And you can have these on a list. You can refer to them, to that New York Times paper. Many of these have been translated in other languages as well. And I always say to the clinicians I work with, even if you have a sex book on your shelf that's within view, that conveys to the person before you that, sexual health is an important topic to you. The next level would be limited information. And I would argue that this also is within probably your training and your bailiwick as well. And so even having the slides that Dr. Altas and I presented with some of the prevalence figures, being able to define certain things, understanding what is a sexual dysfunction, versus what might be an adaptive change in sexual experience that might be expected to get better with time. This is a funny little cartoon that I have on the importance of education. Okay, we took our clothes off. I got on top of you. How soon before it starts to feel good? And Dr. Altas had a slide that shared some of the data on the therapeutic effect of even just basic information on supporting those patients with vulvodynia and vulvovaginal pain. And the exact same thing is found in these individuals with low desire and difficulties with orgasm. We've actually evaluated this in a randomized clinical trial and found very significant improvements in desire just through sharing education, no therapy. So the education would be around, again, the nature of sexual response, sharing common prevalence rates, debunking myths, and providing a space where they can ask their questions to you. There hasn't been a ton of research, but again, what has been done shows that whether the education is on its own or it's education that is weaved within another kind of psychotherapy like CBT can significantly improve sexual function. And if anyone wants any of these references, I'm happy to share them. Also within that limited information is understand, what is the difference between a lubricant and a moisturizer. And this is really important. Lubricants, we always advocate, are intended to make sex feel better, more pleasurable, and should be encouraged during every sexual encounter. And you can counter the person who says, yeah, but I don't have problems in that area, or I'm not dry, with information that's not the intention of a lubricant. It really is to make sex more comfortable, and it's placed externally, and it's used at the time of during sexual activity, versus a moisturizer. And a moisturizer is really quite different. I have a sample of a non-prescription over-the-counter one, as well as a prescription one. And so understanding the difference between these. So moisturizers are more intended to treat vaginal dryness, whether the vaginal dryness is associated with genitourinary syndrome of menopause or other changes, but that is different than a lubricant. We really want to celebrate and normalize the use of lubricant. So in addition to the sex book, have some lubes on your counter as well. So another topic in the domain of limited information is normalizing the role of tools. And so tools might be the use of erotica that is pleasing to the person. Tools might be imagining a fantasy. Tool might also be a vibrator. And I like talking about these as tools because that's all they are. They're intended to facilitate arousal. It's not to replace arousal, but just like the alarm clock that helps us wake up on time in the morning, this can give that bit of a boost. So we want to normalize, we want to ask questions about vibrators. I often get asked, well, which vibrator do you recommend? And I would say, know your favorite trusted sex store in your area. go into that store, talk to the people who work there, and recommend that people actually go in. So if you want to know what my favorite one is, I can tell you during the Q&A. So then we move on, and now we're at specific suggestions. And here is where maybe the folks on logged in tonight might feel like this is getting a little bit outside of my area of expertise, and this would be a place where maybe I need to refer on or perhaps consult with, like to someone like Nicole, who has a lot of expertise in this area. So, for example, being able to describe sensate focus. So we wouldn't say that sensate focus is a therapy per se. It's a touching exercise that has been around since the early 1960s that really is about helping partners relax during sex. It helps take away the goal-oriented nature that tends to happen for a lot of people during sex. And it helps communicate to the other partner about what feels good. And so there's a fantastic illustrated manual that I have here called the Sensate Focus in Sex Therapy book that illustrates as well as describes the stages of sensate focus. And this could be something that you very briefly describe. Who might be suitable for this? Those folks who say, you know, I get really anxious during sex. I adore my partner, it's consensual, I want to have sex, but my mind is not present. I'm just focused on the outcome, and I keep focusing on the fact that I'm not getting aroused and how far I am from orgasm. And you would want to find a little bit about the partner and the relationship, and is this kind of a safe relationship that we could recommend sensate focus in. So this might be something that you feel comfortable recommending, and then you might recommend that they take a look at the book. You can also have knowledge about the role for vaginal accommodators and vaginal inserts, and know where to send people to obtain these. So in particular, those individuals who have a lot of fear of pain, so vaginismus, where there's involuntary tightening of the pelvic floor, and there's a lot of fear of pain, whether there is actual pain or not, but a lot of those folks will have so much fear that they avoid any kind of insertion whatsoever. And so talking about how they can have this within their own control and gradually work through the sizes while simultaneously practicing relaxation can be something that perhaps with some training and some reading, you feel comfortable recommending. Certainly in more complex patient situations, or if there is concurrent vaginal pain, you would want to refer on for that as well. The highest level of PLICIT is intensive therapy. And so this is where you would want to refer on. So know who are the sex therapists or the sexual medicine specialists. I think everyone logged in today is from British Columbia. Most of us do both in-person and online virtual healthcare. And so having a list of names for who some of those folks are. And so just in my last couple of minutes on my slides, I'm just going to tell you about a couple of the most evidence-based treatments, so you at least know what they are and can have some words to go along with them. So again, focusing on difficulties with desire, arousal, and orgasm in females. We have a lot of evidence in favor of mindfulness, which is a practice that includes non-judgmental, present-centered awareness, where the person through repeated practice focuses on parts of the body, maybe the breath, maybe sounds or thoughts. This has been a lot of the work that I've been interested in my lab. This is a screenshot of some of the studies that we've done where we've evaluated mindfulness-based interventions, mostly in females, some studies in males, and some in gender diverse persons with sexual problems. And found pretty strong effect sizes of improvements. And I think one of the really great things is that when people learn these skills, they're pretty motivated to keep practicing them in the long term. That's just a summary of what I've just said. And then another system of intensive therapy would be CBT, or cognitive behavioral therapy. And this is really based on the premise that what we think can directly impact how we feel emotionally, can impact our physiology in our body, and can impact our behavior. So in the domain of sexual problems, avoidance behavior, muscle tension, etc. And what we do in CBT is we directly target the thoughts. So of these different things, thoughts are the most amenable to change. So that could also be something that you describe to a person, especially a person who maybe has a lot of quite negative or judgmental thoughts, like I'm broken, I'm never going to have sex again, no one will ever want to have sex with me. Those very kind of all or nothing catastrophic thoughts. That might be a person who might do well in CBT treatment. And basically this slide just summarizes, there's been multiple randomized clinical trials that show that for a variety of sexual dysfunctions in females and in males, that it can be very, very effective. My last reference, just quick, is, sometimes people say, what about the little pink pill? There are 2 Health Canada approved medications for low desire, for the treatment of low desire in premenopausal females. Flibanserin is an oral a serotonergic, dopaminergic, noradrenergic agonist in the brain. The clinical trials show that people need to be taking it orally daily for at least 8 weeks to show benefit. And the outcome is that for people who are already having sex, it improves the number of satisfying events by 1 per month. So this is not going to help the people who are very avoidant of sex, who are not engaging in sex at all. This is for people who are already engaging in sex, which I would argue is a small group of the people I see with low desire. But in all fairness, I do want to make sure that people are aware of this. Bremelanotide is taken PRN. It's a subcutaneous injection, and it acts on the melanocortin receptors in the brain as an agonist. So it's taken right before planned sexual activity in the person who's willing to do a self-injection. And the efficacy data similarly show that it improves the number of sexually satisfying events by 1 in a month. And they both have some side effects, let's just say that. So in conclusion, I think for this group here, do ask about, don't be afraid to ask details about the nature of their sexual difficulty, what kinds of contexts, what kinds of partners does it show up in, and how much distress it creates for the person. Don't diagnose asexuality as low desire, and do point people to asexuality.org for more information. Always give permission and provide limited information. I would argue that is within your wheelhouse and bailiwick. And as we get to those higher levels of specific suggestions and intensive therapy, consider referring out for those. Education works, so have facts and figures at your fingertips. And last but not least, have your trusted resource list for where to refer people at your fingertips. And this is our Shape Hub. So Kaku is our manager on Shape Hub, where we're a knowledge translation CIHR funded initiative that is really trying to improve awareness about sexual dysfunction and genital pelvic pain across Canada. And we're using this website in partnership with CCAN to share evidence-based information. So bookmark us and stay tuned over the next year as we populate the site with more information.
Amazing. Thank you so much, Lori. Does anyone have any questions for Lori? Okay, Lauren says, thank you so much for both your talks. So helpful. Please, Dr. Brotto, do let us know your recommended brand of vibrators and sex toys so we can talk to patients about it.
Yeah, it wasn't a brand, it was a store. And so I'm shamelessly going to plug women's wear, simply because I know the staff, I've tested them, and they know their stuff. They know, what kind of vibrator to recommend for the person with deep pelvic pain, for the person who has orgasm in very situation-specific encounters. They're very, very validating and normalizing. There's other great sex stores as well. I always trust women's wear on Commercial Drive.
I think you can order online from women's wear as well. So that's a beauty. I know that a lot of people.
But then you can't go in and feel
I know,
the vibrators.
you can't go in and get the. Yeah, it is though. I think that some people there's a portion of people, would you agree, Lori, that would just never step in foot to the store. So it's a good
100%.
option for those people.
Yeah. Yeah, it sure is.
Also, any questions for Melanie as well? But thank you both very much. That was super informative. And I think the important takeaway for me is that, you know, we as frontline people, we can really do a lot to empower people and start off with that, you know, limited suggestions and positivity and getting things going in order to move people on. Is there a list? Like, do you have a verified list of practitioners who are accepting or not accepting patients in British Columbia? Lori, Melanie?
Yeah, I'm going to ask Dr. Altas because we chatted about this today, and she has an excellent list.
Mm-hmm. So, do you mean physicians and MPs? Yeah.
Yeah, physicians, MPs, and I think also like, you know, mindfulness CBT practitioners that are doing this that you could share with us, and then we could share with the staff.
Yeah, so on our website, we have a list of pelvic floor physiotherapists as well as psychologists and counselors. And
Amazing.
the list that we do have are people that we've interviewed them. So we feel comfortable in fully supporting them, and we do have therapists and physios throughout British Columbia. The question about physicians is a great one, because that was actually something that came up when we did that survey. And then after we did the survey, we did small focus groups with physicians in British Columbia. And one of the things that people really wanted was a network of physicians that they could refer to. And it's on my list of things to do, to kind of create that community of local as well as people from outside the Lower Mainland, Fraser Valley, who have an interest, and then kind of cultivating like CME and training for those people. Yeah, so so stay tuned. Maybe check our website in a year.
Yeah, keep looking. Amazing.
Yeah.
Amazing. Thank you so much. I don't see any other questions coming through. I'll give everyone another minute to see. And yeah,
Nicole, sorry, if I could just make one more point. I know when we looked at the Sex Sense demographic, there were lots of young folks who called in or emailed in for help. And we've actually looked at the prevalence of sexual difficulties in collaboration with Sandy Byers, and we found actually quite high rates of the same conditions of low desire and orgasm and arousal difficulties in adolescents and young adults. And Sophie Bergeron did a study focused on vulvovaginal pain in adolescents and young adults, and also found quite high rates. In fact, her rates were higher. I think it was around 19%. So we'll just debunk the idea that these are experiences only of perimenopausal people or older demographics, that there's plenty of young folks that also struggle with these issues.
Yeah. Have that on your mind when you're seeing patients presenting. Okay, great. Oh, question for Lori. What do you say to people with vulvas who are afraid of being dependent on vibrators or sex toys for reaching orgasm?
Yeah, I actually do get asked that question a lot. And I think it comes out of the kind of porn addiction movement or rhetoric, if you will, that if you watch porn, you'll become addicted to it, and you'll become isolated, etc. And so I think it's a very similarly kind of a fear-mongering scare tactic. There's absolutely no data to support that whatsoever. That has been investigated in research. And in fact, what the research finds is that people who use vibrators have actually higher rates of partnered sexual activity as well. So what it's probably doing is it's probably eliciting more desire for them, because sex is becoming more pleasurable. So they're in turn more interested in other kinds of sex as well.
Yeah, very interesting. Thanks. Great question, Silas. Okay, and I was just going to offer, if anyone has any additional questions, please send them to myself or Emma, and we can pass them on to Lori and Melanie to be answered. But thank you so much. I am going to give us a 3 to 4 minute stretch break, just because we've been sitting for about an hour and a half, and let our wonderful presenters be on their way and enjoy the rest of their evening. Thank you so much. And then we will gather in 3 to 4 minutes to have a brief half an hour session town hall with Tiffany.